Good afternoon, Europe. Good evening, Asia and Australia, and good morning, America. And welcome to this TTS webinar. My name is Estephan Arredondo. I'm from Spain. I'm the current chair of the TTS Allied Health Committee. I'm also the technical director of Besides Biotechnology, a BioIBT company. Today, the TTS Allied Health Committee organized a very interesting webinar with the topic empowering allied health professionals through the educations in organ, tissues, and cell donation and transplantation. So the webinar will last around 60 minutes, and we will have two panelists, and also we invite you to use the chat to put your questions, that at the end of the presentations we can discuss and answer your questions. Please don't be shy, and we will be happy to discuss and to have interaction with all the attendees. Today I'm pleased to invite to Floden. She is the co-chair of the committee. She is a director of competence development of the South Albert Hospital and also associate professor of the Gutenberg University. She has more than 40 years of experience in clinical nursing and 60 years of experience as a transplant coordinator. So also she's very active in development of international programs and international cooperation. So Anne, welcome, and the floor is yours.
Thank you very much, Estefan, for the introduction and for the welcome word. And I'm also honored to co-chair with you at the Allied Health Professional Committee. We go way back in this topic, and we are dedicated to it. Today, we are very fortunate to have two excellent speakers who bring valuable experience in developing and implementing education programs in this field. And the first speaker we are going to listen to is Carmen Blanco from Spain. And Carmen is the head of educational programs at the DTI Foundation, and she has been involved in the organization for more than 300 international courses, as well as the Masters in Donation and Transplantation of Organs, Tissues, Cell at the University of Barcelona. And Carmen, you will present on educational initiatives that support the allied health professionals in organ and tissue donation and transplantation, and you will highlight the practical approaches to training and capacity building. We're looking forward to that. And the second speaker is John Boyd, and John is the director of tissue acquisition at Lonza, leading a multidisciplinary team that supports clinical and research initiatives relying on donated organs and tissues and cells. And additionally, Jonathan is the founder and CEO of AlloEd, which provide technical training and education to current and future donation and transplant professionals worldwide. And John, you will share your perspective of international education initiatives and approaches that support the capacity building and professional development for allied health professionals working in organ donation and transplantation system. And now we give the floor to Carmen. We're looking forward to your presentation.
Thank you very much, Anne and Stefan. Thank you very much to the TTS Allied Health Professionals Committee for giving me the opportunity to talk in this webinar. I declare that I have no conflicts of interest. And I will start saying that we focus on the donation and transplantation best practices in the world, such as Spain, Portugal, Italy, or Croatia, as some examples. This literature says that professionalization of the activity is important and can be achieved through continuous training. Obviously, the success of the model is not only due to this, as you can see here, also institutional support, legal framework, or quality plans are necessary, but the professionalization of the activity and continuous education plays an important role and are part of the clues for success. When we talk about education in the field of donation and transplantation, we can identify 3 levels. The first one is the university level, involves graduate and postgraduate students. The second one is what we call the hospital level, where education involves professionalization of the healthcare professionals involved in donation and transplantation of organs, tissues, and cells. And the third level would be the community. Oops, sorry. Let me just, okay. Which involves not only education, but also social awareness towards donation and transplantation. This is an example of education at university degree level from the University of Barcelona, which since 2004 counts with the following training activities on this field. They organize a subject on donation and transplantation at the third level of the medical degree. Also, there is a seminar on organ donation organized by the students from 6th year. And also the UB organizes every year a University Day on organ donation in which several schools are involved, not only medicine school. This type of trainings helps improve positive attitudes towards donation among the future medical reference for society. And an example of the third level is, for instance, this European project that was funded by European Commission. It was a tender project called Eudonorgan, and it had a working package addressed to non-health professionals and public awareness, in which training and public events were organized. Now I'm going to focus on the second level, which is the professional training. We could talk about postgraduate level. This type of education can be at university or not, but what is crucial is that it is about professionalizing donation and transplantation. We must take into account that multidisciplinary teams must be created, and these teams are formed by physicians and all the collectives that belong to the allied health professionals. These teams must be provided with knowledge and skills through teamwork, motivation, teaching innovation, so that they become self-thinkers and are empowered to lead donation units, transplant programs, tissue bankings, etc. Training healthcare professionals have its particularities, as we are dealing with adults and their context and previous experiences are significantly relevant. Therefore, educational programs addressed to them must take into account andragogy in contraposition with pedagogy. They must involve transformative and experimental learning and be especially contextualized. Andragogy is the theory, science, and practice of adult learning, distinct from child learning, which emphasizes self-directed, experience-based, and practical education. Andragogy prioritizes collaboration over instruction, encouraging participatory methods like discussion, workshops, rather than lectures. According to Meziro's 10 phases of transformative learning theory, adult learning must be a reflective process. When applied to health professionals, this reflective process empowers them to act as change agents within their workplaces and communities. Adult learning must be as well experimental. Therefore, learning by doing methodologies should be applied. In health professionals training, clinical simulation, for instance, become relevant to achieve the learning goals. And finally, context in health professionals training is also very important and must be taken into account the culture, religion, country's legal aspects, the health system, and clinical practices background. In this context of adult learning, DTI Foundation has more than 30 years experience in training health professionals in this field, in donation and transplantation field. For those who are not acquainted with DTI, we are a non-profit organization with the commitment to train and advise public and private organizations in the development of disease donation and transplantation systems, and therefore to raise organ donation in the world and consequently improve people's quality of life. These are our areas of expertise, which is not only training, but also international cooperation and research development. Within these 30 years, more than 400 countries have been carried out in 48 different courses in 48 different countries. DTI training offer is organized in different levels, from the elementary to a master's degree, and is provided in different modalities, mainly face-to-face, but also online and blended modality, which is a combination of both. We are very proud to count with a great network of international experts in this field, from the teaching perspective, but also with many skills, attitude, and most of all, passion towards donation and transplantation. And they are all able to transmit this to our participants. Our educational methodology is based on the adult learning aspects that I have explained before. And for instance, in our face-to-face educational programs, we provide interactive lectures, small group activities, case-based learning, process mapping, gamification, and simulations, and also supervised hospital observerships. In our online training formats, we use educational methodologies such as flipped classroom, web-based applications, digital storytelling, virtual reality, and streamed simulations. The contents of our training programs are very diverse. Most of them are about organ donation and procurement process from a clinical perspective, but also from the management perspective. And one of them, other ones are about organ transplantation and tissue banking and cells. I will present now our master's program, which is a specific degree from the University of Barcelona that provides a holistic view of donation and transplantation of organs, tissues, and cells. 22 editions have been organized so far, and it is addressed to professionals willing to be professionalized in this field. In this figure, you can see the number of participants trained since 2010, which is a total of 345 people from more than 50 different nationalities. And in this figure, you can see the academic background of the participants trained since then. As you can see, 66% are medical doctors and 34 are people from allied health professionals collectives. If we look into the profiles of allied health professionals background, we see that most of them are nurses, but there are many other profiles represented, such as biology, biotechnologies, and biomedical engineers, psychologists, pharmacists, social workers, forensic doctors, and health system managers, among others. This is the master's program structure. These modules, let me choose the point. Yeah. These 4 modules are like the theoretical ones. These 2 are like the common modules for all students. And then they can choose between these 2. And these are 2 transversal modules across the whole program. And I will explain a little bit more about the contents of each one of them. In the organ procurement module covers the whole process of organ donation from disease donation, starting with donor detection and identification and going through the whole clinical process of disease, both DBD and DCD procedures. In the leadership quality management module, participants learn about best practice models, management and leadership, quality programs, optimal cost-effective measures, and also innovation. The organ transplantation module goes through immunology, the post-transplant care, and also living donation process. Then we have the tissue banking and advanced therapies modules that covers topics such as tissue donation and evaluation, ethical and regulatory aspects, quality, and goes through each type of tissue banking, which is eye banking, cardiovascular, musculoskeletal, and skin bankings. And other topics are also covered for advanced therapy medical products, stem cells, and core banking, core blood banking. Finally, the transversal module that I mentioned, diving into the donation and transplantation process, includes a virtual reality visit to a hospital and also some tailored interviews with our experts according to the participants' interest and learning needs. And finally, the other transversal module of this master is the final master's dissertation. So participants, to complete the program, they must write a dissertation based on the applicability of the knowledge and competences that they are acquired. They are assigned a tutor who guide them through, and the dissertation can be on research, on systematic view, or a study case. So since this master offers such a holistic view, we especially address it to allied health professionals because of this multidisciplinary point of view that compiles. Now we'll talk about the methodology that we use in this program, which is designed to foster competence-based and interdisciplinary and practice-oriented learning in a flexible and online environment. It integrates theoretical knowledge with real-world application through real-world application and online webinars or live sessions that we call that provide opportunities for direct engagement with the faculty and the other students. In the virtual campus, students follow a self-directed and asynchronous learning that allows them to manage their own pace, the schedule. The learning materials provided include recorded lectures, case studies, and interactive multimedia content. There is a case-based and problem-solving approach, and also collaborative learning is applied with virtual discussions and group assignments, simulating the multidisciplinary nature of donation and transplantation teams. And all this with the guidance from our international experts and a continuous assessment to follow the learning process. To finalize, I am very proud to say that we have gathered along these years more than 20,000 participants around the world. These countries in blue are the ones where there has been at least one participant, and these are the total numbers of face-to-face, e-learning, and master's degree modality. Also, I will show you this figure where you can see the correlation of the organ donation rates that published in Arredondo database and the number of participants from 7 countries where the train has been provided at the national level and for a prolonged time, which has been the cases of China, Saudi Arabia, Thailand, Emirates, Italy, Portugal, and Slovenia, as some examples that we have taken. It shows direct impact of training professionals involved in organ donation and transplantation process and the increase of the organ donation rate in their countries. So I will finalize saying that the more investment in training, the better donation systems we can have. And thank you very much for your attention. I'm very happy to be ready for some comments or questions that you may have.
Thank you very much, Carmen, for the excellent presentation. And I think that also you present very nice tools for the allied health professionals that can take for bring more experience for the countries. I have a question that maybe you will answer at the end, but one of the main, when we have been talking with all the committee, one of the main challenges the allied health professionals is the training and to have one curriculum accepted by the countries. So maybe I will ask you this question at the end, and also to you, maybe Jan. But I think that also is important. How to know how these projects or these programs can help to the allied health professionals to establish a national curriculum and recognition in the different countries where they are working. So saying that, I also will introduce to the second speaker, who is John Boy. He is the founder and CEO of Aleot from the USA. So John, the floor is yours.
Thank you, Estephan. Thank you all for the chance to share some of the projects we're working on. The overarching focus of this presentation is targeting allied health, in particular, how we interact with medical legal death investigation professionals. And just a quick overview of some of the things we're working towards. Of course, the donation and death investigation side of things is a massively underserved area of training and education, at least in the United States. And what we're working towards is providing not so much a graduate level type of program like DTI or even continued education like associations like TTS or AOPA or others would provide, but to support the implementation of core competence with organizations as they get started. So doing things like hands-on tissue processing training or building the initial employee development pieces for emerging and developing programs. And for the medical legal side, in the United States, these professionals may be referred to in different terms. So for simplicity, I'm going to stick with medical legal death investigator or a death investigator throughout the presentation. But at least in the United States, these can be medical examiners, forensic pathologists, coroners, justice of the peace. And these systems are different state by state throughout the US. So where I live in North Carolina, we have a medical examiner system, but it is made up by a chief of the state, and each of the counties will have designees. The designees throughout these regions, as an example, could be paramedics or nurses. So these would be pretty much equivalent to a coroner in other states. However, they are not elected. So it is complex to say the least, and from what I've gauged in other countries, it also differs quite drastically, country by country, probably close to how we differ state by state throughout the U.S. But ultimately, the death investigators are individuals that are responsible for determining the cause and manner of death. It's also important to highlight what jurisdiction is. So in the United States, it differs state by state, as I mentioned. But so, for example, coroner system states, in many instances, the death investigator will go on the scene. Where I am in North Carolina, the law enforcement is considered the owner of the scene, and the death investigator is the owner of the body and any of the surrounding information. These are the only people in the United States, aside from a judge, who can restrict donation. So even if the person is registered or the family decides to donate, a death investigator can reverse that and prevent donation from moving forward. When we refer to evidence, in this setting, evidence can be physical items. So, of course, any abnormality or injury on the body, but also relevant information. And this includes so much of what we gather and generate throughout the donation process. So in this perfect world, we have a phenomenal harmonious relationship between the worlds of donation and death investigation, because we're ultimately both serving the decedent, the donor, serving their family, we're supporting public health. And I think there's a misconception where in how we approach trying to work with death investigators. I've been in meetings commonly where it's almost like the donation team points a finger at the death investigator as if you're the bad guy, you're restricting, you're denying, or getting in the way of what we're doing. The narrative is often that donation does not interfere. And even previously, there was a white paper published that referenced that there had been no disruption to death investigation and determining cause and manner of death as a result of donation. However, this reference was really to litigation, so that there had been no no charges and no conviction that was interrupted as a result or a byproduct of the donation process. However, the reality is donation does interrupt. It does disrupt. We do create artifact. If you think of just going through the basic process, if someone has an extended vent time, there are changes. If we are recovering skin before the death investigator views the bodies, we are creating a disruption. Oh, and I think it's our responsibility as donation professionals to own this and to remember that it's our responsibility to fulfill the wishes of the donor, to serve waiting recipients. So we have to bridge these gaps. To do that, we also have to recognize that the death investigator is always going to place the highest emphasis and priority on their investigation. So to do what we need to do, we have to support their process. We have to enable donation. And to do that, we have to find ways to preserve evidence and mitigate the potential disruption of donation. Many eligible donors, and I would say most, especially for younger donors, are under the jurisdiction of a death investigator. And prior to the publication of a document I'll share in just a moment, there was no broad spectrum direction on how to mitigate these disruptions. And a lack of procedure ultimately leads to restriction. And previously, there was not a significant amount of data. However, we concluded a small sample survey with the National Association of Medical Examiners that was distributed by the Association of Organ Procurement Organizations late in 25, which captured some of the restriction data for 2022 and 2024. So from the model, we know that there are over, and it's closer to, if this averages hold true, around 1,200 transplantable organs lost per year in the United States alone for ME and coronary restriction, and over 9,000 total restricted eye and tissue donors. So in the United States, we have the opt-in system, whereas of course, I'm sure everyone's very familiar with Spain has the far superior opt-out system. But in the United States, this would mean that over 10 million registered donors would be unsuitable to donate based on ME and coronary restriction. Previously, what had been presented was the rate of restrictions for transplantable organs that had already been placed. So we were missing a significant amount of data. We were missing all of those donors where the ME or coroner restricts the case or denies donation from moving forward at referral or when we're approaching the family, so before placement has been completed. So this data, how we historically approached this, showed a much smaller sample, and we had no data whatsoever on the rate of tissue and eye donor restrictions. Ultimately, what we see through the report is that roughly 6% of transplantable organs are potentially lost, and roughly 13% of suitable tissue and eye donors are lost every year. So in 2018, we published the first guide to medical examiner and coroner cases. It was jointly published. The second edition was jointly published in 2023 with AATB, AOPO, EBAA, and the International Association of Coroners and Medical Examiners. The objective of this document was to provide some form of uniform approach to mitigating that disruption, to outline practices and procedures that donation professionals can implement to better serve the allied health professionals in the ME and coroner space. The way I like to highlight this for folks that don't have an established support system for their death investigators is that if we are looking at documents that impact or generating tests and diagnostics that impact how we view the donor, their suitability, or their eligibility for tissue, then most likely these data have some form of impact on the death investigation process. And in many instances, we are accessing this information far before the death investigator can. We're getting information like the donor risk assessment, that medical social history that provides a lot of detail into traits like illicit drug use or comorbidities. And when we are trying to gain permission for donation to move forward, these elements can be integral in determining whether or not the death investigator will permit donation and can play a big role in determining the cause and manner of death. Especially in the case of of organ donation, we have copious uh, access to diagnostics and tests. And we still have plenty of access on the tissue side as well. That can be our infectious disease testing results, micro for each of the tissues swabbed, and of course, all the diagnostics that are a byproduct of moving through the donation process. In some instances, we have access to records that may be challenging for the death investigator to attain. And we're getting these, as mentioned, well in advance of when they would have access. So creating a process where we have a direct and clear path to share this information can make a big difference, not only in improving these relationships, but also enabling donation to take place. The physical assessment is also a really important piece of this. And throughout the guide, we've highlighted some of the core things that need to be documented, and are advocating for descriptive terms, not diagnostic terms. And I should actually mention there's a QR code at the top right of this slide if you want to download the guide. It's published through the AATB on the AATB website as well as several other locations. So throughout the guide, we've walked through this, and especially for tissue, pre-autopsy, of course, is critical and always necessary for organ donation, obviously. But when we go back to that notion of donation doesn't disrupt or doesn't interfere, if you are making an incision through a site, if you're recovering skin, removing IVs, IOs, or any of the other medical artifacts, inevitably you are altering those physical findings. And if we are viewing the body before the death investigator, innately we are disrupting, we are creating a change. Even better than the physical assessment and that documentation is photography. So throughout the guide, we've outlined practices for forensic photography, including full body photographs, how to scale and document injury, and intraoperative photographs. So this can be exceptionally beneficial on complex cases, homicides, and pediatric deaths in particular. An example is there's a pediatric case that we had worked through when I was on the OPO side, where we couldn't officially rule out potential abuse. So what the death investigator had us do was take photos with each and every step throughout the recovery process. So from incision in each step. So if it's transecting the pericardium, take a photograph. Dissecting the aorta, taking another photograph. So that step-by-step provides a great view into everything that we saw and helps put the pieces together so that they have a full and comprehensive view of everything that happened through the donation process. Essentially, we want them to be as close to being able to see like they were in the operating room with us as possible. The big challenge with this oftentimes is staff buy-in. So I've heard people say, well, we're practically doing their jobs. And I like to remind people that the death investigators can do what they need to do without us, and many times much easier without us, because if we slow down their process, we're calling them in the middle of the night. And again, to one of my initial points, it's our responsibility to make sure that donation can move forward. So having management and leadership buy-in for these steps is important, but also getting staff on the same page, because if photos are taken improperly, it really adds no value. And shifting the narrative to the support of the death investigation process being a portion of donation is really important. So we move away from that mentality of we're doing the work for them to we're doing what we need to do to enable donation and to maximize the gift of life. Radiography, especially on organ cases and other diagnostic imaging, is incredibly valuable. Of course, being able to demonstrate the function of an organ is really important. And for tissue, in particular with heart for valves, pediatric heart for valves, skeletal surveys can make a massive difference. That is very common for these cases to be denied, and the frequent reason is they're unable to rule out potential abuse or trauma, right? So with pediatric heart valve cases, there may not be any external signs of injury or asphyxiation. So a cautious death investigator is going to say no to donation because we don't know what we're missing. And then they're concerned that making an incision, recovering the heart, completing the dissection is going to disrupt some form of finding that could impede their ability to determine cause and manner of death or to defend that case if it goes to trial. So imaging gives a great glimpse into what's beneath the surface and is a supplement to uh, and it builds upon taking external photos and completing the documentation of physical findings. For the pediatric heart valve scenario, what I used to do again at the OPO side is we went through this decision tree process for pediatric heart valves, where we would work with law enforcement, work with the hospital, and essentially identify if there's any apparent risk of abuse. And if none is identified, we would move forward with completing a skeletal survey in collaboration with the hospital. The cases that we worked through when I was in this position did have a 100% release rate. It takes a lot of effort to make these cases go through. Lots of time, lots of support, and it can be done. So in the 1 year of implementation when I was with the OPO, we had a 185% increase in heart for valve donation on medical examiner cases and an overall reduction in restriction of 65%. But without that engagement, it's really not possible. I always joke when talking with international folks that about the overdose rate in the US, it's significantly high. And as a result, toxicology samples are imperative. What we've outlined throughout the guide is appropriate means of collection, what samples should be collected, how they can be preserved. And this is really critical for both organ and tissue. Admission samples, ante-mortem admission samples are very important. So in a scenario where you have an organ donor that is in the ICU for weeks, even just days, there's a solid possibility that the admission sample may be discarded at that point, and then the samples that might be taken before donation takes place or immediately before are going to be negative, right? So making sure you have practices in place that urge staff to preserve those initial admin samples is imperative. For postmortem, we walk through the collection methods, which have a really significant impact on the accuracy of determining or identifying any substances postmortem. So a good example is collecting peripheral femoral blood instead of a subclavian draw or a heart draw for the blood sample for toxicology. For example, if someone aspirates and has ingested a pill and that substance sits around the trachea and could diffuse, you might, from a subclavian draw, you're going to have a significantly elevated, a falsely elevated drug content level. The same thing is true with heart sticks or heart draws postmortem. So you'll have a postmortem redistribution essentially where the drug content will pool to the center of the body, demonstrating a falsely elevated rate. There are some studies that show up to a 5,000% elevation when drawing samples that have been impacted by diffusion or redistribution. So drawing a peripheral femoral sample eliminates this risk of the postmortem artifact. Throughout the guide, we also have outlined various steps for providing samples like vitreous, liver biopsies, and other toxicology samples. Of course, only on the tissue side, clots play a big role. If any of you have worked, completed tissue recovery, you've probably seen a case where a forensic pathologist has made an incision in the posterior aspect of the leg, trying to look for DVTs. Of course, this then precludes us from being able to effectively recover musculoskeletal tissues. The same can be said for pulmonary embolisms. If there's a concern, the forensic pathologist may restrict the heart. And so what we've outlined throughout the guide is means to document, preserve, and collect any of these clots. And the bottom left is a case that my team had worked. And this was a wonderful example of how appropriate documentation, photography, and communication with death investigators can make all the difference. So this was an individual in their mid-30s. It was a sudden collapse. He was witnessed collapsing on the sidewalk and passed before arriving to the emergency room. Initially, this case was a medical examiner's case. And when we started to do the recovery, we obviously found a significant amount of blood, ultimately identifying two small tears in the posterior aspect of the aorta. When we reported this to the medical examiner, the entire focus of the case changed because this shifted from requiring an autopsy to being a natural death. Ultimately, the attending physician in the emergency room signed the death certificate on this case. But if we didn't have these practices in place, this may have gone undiagnosed with the heart valves or heart being recovered. It would have been noted with cardiac pathology post, but of course, this enabled the family to also get a much faster cause and manner of death and have the death certificate signed out, given that we were able to confirm it was a natural death. While we have published the guide, unfortunately, we've certainly seen that written material doesn't go as far as communicating with people and talking through scenarios. So the next phase of this, since we published the guide, is hosting a workshop to go into deep detail about how to preserve evidence and mitigate disruption. The first workshop is going to be in June, and currently about 1/3 of the attendees are death investigators. I'm really excited to see that. It was unexpected. And what we've seen so far is tissue programs and OPOs are actually sponsoring the travel and attendance of MEs and coroners to participate in this. I'm excited. I hope it continues. Obviously, there's a need. And again, the driver here are those missed opportunities. And I think if we're able to engage both the death investigators and donation professionals, giving this reciprocal training and sharing an environment that promotes collaboration, not contention, where we're moving away from this narrative of the death investigator is the bad guy, and we're doing what we have to do to preserve the opportunity for donation, we can see a reduction in these cases. But without that engagement and collaboration, it's really not possible. So what's next for this particular project? We're currently, since we now have data that supports and identifies this massive rate of restriction, we hope to have funding in the US to do this regionally, ultimately to provide the training for free to participants who want to join in. We're currently putting in drafting proposals to try to do this workshop 9 additional times regionally throughout the US. And also trying to promote a higher level of engagement at national associations or international associations focused on death investigation. The goal would be after we roll this out completely, if we're able to do this regionally and engage the significant volume of donation and death investigation professionals throughout the US, is to see a 1/3 overall reduction in restrictions. For donation programs that have implemented such practices, it's been demonstrated that we can do it. But it's a lot of work. And as I mentioned, I think changing that narrative to how can we support you instead of what can the death investigator do for us can make a massive difference in moving this forward. That is all for me. Thank you very much.
Thank you very much, John, for your presentation, and also thank you, Carmen. And now we open the floor for the audience to ask their question. You could do it in writing in the chat, and we have received a couple of questions, but I would like to start with you, Estephan, to go back with the question you had after Carmen's presentation about the curricula. If we could start with that.
Thank you. Maybe it could be for John and for Carmen. As a chair of the Allied Health Professionals Committee, one of the main requests that the several undeveloped countries in terms of organ donation and transplantation is how they can access to the training that you are offering, what they need to professionalize the activity. Do you have any experience of collaboration with the countries, and how you have done that? Maybe Carmen, you can start.
Yeah, sure. I mean, we have had experiences in training allied health professionals, and what is crucial is the institutional support to development, because obviously, as an individual, it is difficult to access. But the development of the organ donation system to be a successful system has to count with institutional support. So when we normally train these collectives in a specific country, the people behind organizing these and supporting these are the government or the hospital authorities of a region or for a specific hospital, etc. So we need them to understand that these multidisciplinary teams are important, that all professionals, because traditionally it was a medical, physicians were in charge of it, but it's not anymore. And we've seen it in other successful models in some countries, like in Sweden, where Anne's from. So that's what they need to access this program. And when we have done it, has been like this, with a collaboration between their institutions and ours.
Thank you, Carmen. And John, do you have any experience on that?
So for access internationally, I mean, of course, online is very helpful, but I would say a lot of what we're focused on is providing more niche training in very targeted and specific areas that is really geared more towards technical, on the ground type of personnel. So like we're doing with the US program with the objective of hosting regionally, we're really supporting more of the folks that are not able to have a travel budget, right? So that's the idea, is getting to people instead of having people come to us. So that will be the long-term goal. And through the AATB education portion, when I was on the AATB team, we had a fairly significant amount of international attendees, not on the allied health space, though, of course, because AATB targeted the professionals already in the tissue banking space, so slightly different modality.
Thank you very much. And I have followed the work you do in DTI for a long time, and I'm so impressed about the work you have developed over the year, plus 25 years. And also hearing you, John, talking about your work, that is really impressive. And it is like you say, Carmen, that just have one or a few professionals is not enough if we want to change a country. So we have a lot of work to do together, and we have to bring that back to our group, Estephan, I believe, to see what we can do with our colleagues in the Allied Health Committee. But we have two questions here. First, it is Lucas. Hi, everyone. Regarding the educational programs, is there any specific about HLA compatibility or discussing cases about bone marrow or renal transplant, renal patients? We have biochemists here focusing on that area, and that is Argentina. I think you, Estephan, may answer that. We have our colleague in our group from Argentina. Do you have more insight about the HLA?
In fact, we develop, maybe John and Carmen can ask first if you have a specific course or topic in your programs about that. But also, the last webinar that this committee organized was about HLA typing. So also you can consult the information that is available in the TTS website for all the members of the society. I don't know, Carmen, you have specific chapters of that in your program?
Yeah, in fact, HLA compatibility and bone marrow topics are included in the first one in the organ transplantation module, which, by the way, I didn't mention, but these modules composing the master's program can also be enrolled individually. So if you are only focused on one topic, you can do it so. And the bone marrow is a topic of the tissue banking and advanced therapies module course. So it is, but obviously it is not. I mean, it's one topic among all of them. So I'm not sure if they are going to be as deep as maybe they are needing to.
And John, do you have anything about the HLA compatibility?
So for that side of the training, we are essentially building bespoke. So as like I mentioned early in the presentation, for developing an emerging program. So essentially the way we're approaching it is we have the high level content, and if there's a health ministry or program that's getting started, we would offer this training, but it's not a standard fixed offering like DTI.
Thank you very much. And also Lucas from Argentina say thanks to you for your answers. And then we have our colleague Juntaro from Tokyo. He's writing, thank you for your informative presentation. We have a similar issue here in Japan. I may have missed it, but how do you share the data and photos with the death investigators? Is there a database that the death investigator can access?
Great question. So there are a few pathways, and I didn't touch on that one, the photograph section, but the IT support is really important. So of course, if you're taking sometimes 40, 50 high resolution photos per case, that takes a lot of storage. There are several ways that this information, including the medical records, the donor risk assessment, medical social history, and photos, can be distributed. And it really depends on what you have access to, what your IT permits, what your legal permits. If you have encrypted email, that's an option, but the challenge is going to be file size. So a secure SharePoint site or any form of cloud-based access also works, where you can have a secure code sent to the death investigator and they can download virtually. I've had cases where, especially in very rural areas, maybe the county coroner doesn't have a government-issued laptop and has then requested that they be sent on an encrypted flash drive. Another option is if you have systems that are integrated. So in the US, we use a lot of folks use iTransplant or Donor Connect or other such systems. There's an equivalent system for death investigators called MDI log. And many of these systems have an integration between the donation record system, the EMR, and the MDI log. So that's best case scenario where you can just port over the data to your investigator, but that depends so much on what they have access to. So again, the scenario of a rural small county that maybe doesn't have the budget, right? So they're most likely not going to have the electronic systems. So I hope that was helpful and great question. Thank you.
Thank you. And Carmen, do you have anything you could share from Spain, your expertise from international wise, how that can be done?
Well, about this topic specifically, we are not very familiar with it. So,
okay. And Gentaro say thank you. And we have some panelists leaving, just sending thank you. Do you have any additional question, Estephan?
No, not so far, but because of the time, I think that we can start with the conclusions. So
I think so too.
So maybe first of all, thank you for the panelists for the amazing presentations that you have developed. And as a summary, as an allied health professional, and I think that in order to access to the training, we need the support of the government, and we need the support of the authorities in order to make a regular training and also to professionalize the activity of the allied health professionals. Also I want to mention that the Transplantation Society is organizing its next Congress next September from 20 to 23 of September. So we will be there. I think that
yes.
Carmen also
Yes.
and you, maybe young, also all of us, we will be there. But in this conference, we will have a specific panel dedicated for the allied health professionals that will be done on September 20. So this panel will be mainly focused for nurturing, but all the allied health professionals are invited to participate in this activity. And finally, also, I would like to remark that please, the deadlines to send abstracts for the conference is still activated. The deadline is on March 19, so we would like to have as many abstracts and as many words presented representing our community and representing the diversity of the allied health professionals that we are working in organ donation and transplantation. So thanks to all for your participation. I think it's only just 1 hour, so everything on time. And thank you, and see you in the next webinar.
Thank you.
Thank you so much. Bye-bye.